Welcome back. Let's run through a few scenarios that illustrate how an EMS response might play out when abuse or neglect is involved. As I describe each case, think about the red flags and the appropriate actions, which we've covered. Case 1, child abuse. You and your partner are dispatched to a home for a 3-year-old who fell downstairs. On arrival, you find a 3-year-old boy sitting quietly in his mother's lap. He's unusually quiet, not crying, or behaving like a typical injured toddler might. You immediately notice some bruising, a purplish bruise on his left ear, and some yellow brown bruises peeking out from under his shirt on his back. The mother repeats that he fell down a flight of stairs this morning. While examining the child, you find a fresh bruise on his forehead, which could be from a fall, but also older bruises on his back, and even what feels like a rib deformity, possible older fracture. These injuries don't quite match one simple fall. Bruises on the ear and back for a toddler are especially concerning. Recall the 10 to 4 rule, torso and ears bruising in under 4-year-olds. The father is in the next room looking nervous, and the child flinches when the father pokes his head in to ask what's going on. The child doesn't answer when you gently ask him about the fall, and instead he buries his face in your chest, seeking comfort from you, a stranger, which can sometimes indicate he's not getting that feeling of safety at home. At this point, your red flags are high for physical abuse. So what do? You signal your partner to quietly request police backup, you fully expose and assess the child with the mother's hesitant permission, and document every bruise and injury. In the ambulance, away from the parents, you softly ask the boy if anything else hurts and if he feels okay. He's too young or too scared to give details, which is common. On the way to the hospital, you mention to the mother you notice multiple bruises that don't look new. Her explanation is vague and shifting. Oh, he's so clumsy. Maybe last week he fell off his tricycle too. You don't press her hard or accuse her. That's for investigators later. But you've seen enough to be pretty sure this is non-accidental trauma. At the ER, you inform the pediatric nurse and doctor of your concerns outright, listing the injuries and inconsistencies. After the call, you call the state child abuse hotline to file a report providing all the details from your run sheet. The police who arrived also took photographs and started their investigation. Thanks to your careful observation and action, this child will be examined thoroughly and Child Protective Services will get involved to ensure his safety going forward. Case 2, elder neglect. It's early afternoon when you're called for an elderly female unconscious by a neighbor. You arrive to find an 82-year-old woman in bed, unresponsive but breathing, with a very low blood pressure. The smell of urine and feces in the house is overpowering. The patient is lying in a urine-soaked bed, wearing a nightgown that hasn't been changed in ages. She is extremely thin, skin and bones, and you find multiple large bed sores on her backside, some of which are open and infected. The daughter arrives from the store and says she's the caregiver. She seems a bit overwhelmed and says, she's been refusing to eat or drink the past couple days, and I was just out getting her medicine. You notice that the kitchen has almost no fresh food, and the patient's adult diapers in the trash are overflowing, suggesting infrequent changes. The patient's lips are cracked and her eyes are sunk, clear signs of dehydration. This is a classic picture of severe neglect. Whether the daughter is malicious or just unable to care for her mom properly, the result is the same. The elder is in a life-threatening state from lack of care. So, what do? First, you treat the immediate issues. Start IV fluids for dehydration, check blood sugar, maybe it's low from malnutrition, etc. During transport, you gather more history. The daughter's explanations don't fully account for the extreme condition. She might be defensive or maybe tearfully admits she's overwhelmed, but either way, APS needs to be involved. You document the woman's condition thoroughly. Patient found in soiled bed, approximately 90 pounds, estimated, very thin, dehydrated, with multiple stage 3 pressure ulcers on sacrum and heels. At the hospital, you pull aside the social worker and say, this appears to be a neglect situation. You call Adult Protective Services as required by law to report elder neglect, giving them all details. In this scenario, the patient may not be able to speak for herself, altered mental status, perhaps from a urinary infection due to neglect or general sepsis. So your observations and report are critical. A PS can investigate and potentially arrange for better care. Maybe social services can provide a visiting nurse, or maybe the elder needs to be moved to a skilled facility. If the daughter is found to be negligent, there could be legal consequences, but also perhaps support to help her if she's just truly unable. The key is, you identified that this wasn't just an illness, it was an outright result of neglect, and you took action to get the ball rolling to protect this patient from further harm. Case 3, domestic violence. You're called to a home for a woman with an arm injury. On scene, you find a 30-year-old woman with an obviously deformed left forearm, likely a fracture. She's cradling it and looks teary-eyed. A man who introduces himself as her boyfriend is hovering. He's doing most of the talking. She slipped while mopping and fell on her arm. The woman is avoiding eye contact, and you notice she has some fading bruises around her eye and on her upper arms. As you ask her what happened, she starts to speak quietly, but the boyfriend interjects, "It was just a silly accident, right, hun?" And she falls silent. Red flag. This fits the pattern of intimate partner violence behavior we discussed. Her affect is fearful. She flinches once when he raises his voice slightly. Now to you. What do? You should suspect domestic violence. You need to get her alone to confirm, and also to ensure she can speak freely. You convince the boyfriend that she should go in the ambulance for further evaluation. We need to check her blood pressure and pain in a controlled environment, sir. You can follow us in your car. If he insists on riding along, that complicates things. You might say due to policy he can't ride because we need space for treatment. Some EMS systems might allow it, but you can try to discourage it. Let's say he agrees to follow in his car. Once in the ambulance, your partner starts driving, and now you have a private moment. You speak gently. Listen, that story about slipping, I just want to make sure. Did something else happen? You're safe with us. She breaks down crying and nods, saying in a small voice, "He grabbed me and pushed me. This isn't the first time." Now she's admitted it. You provide emotional support. "I'm sorry this happened. It's not your fault. You're doing the right thing, getting help." You continue care for her broken arm, splinting, pain management. Now it's imperative to handle this carefully. She's still fearful of what will happen when he gets to the hospital. You let the receiving hospital know via radio to have security present upon arrival. You phrase it discreetly, requesting security on arrival for a possible domestic situation. At the hospital, you make sure to speak to a nurse or doctor out of his earshot and say, "She confided that he hurt her. We've notified police." The police arrive and take him aside. Because of her injuries and statement, he may be arrested. You or the hospital staff give the patient information about a local domestic violence shelter and hotline once he's not around. In your report, you quote her, "Patient states boyfriend pushed her, causing injury." This scenario shows how an EMS provider's quick thinking, separating the victim, gently encouraging communication, and looping in the right resources can start the process of getting someone out of a dangerous situation. It's delicate because confronting the abuser directly or mishandling it could put her at more risk. But by coordinating with the hospital and law enforcement, you helped ensure her safety that day. Case 4, Dependent Adult Abuse. Your team is called to a group home for adults with developmental disabilities for a seizure involving a 40-year-old male resident. Staff say the patient has a seizure disorder and had a convulsion. When you assess the patient, who has the intellectual capacity of a young child, you find he is a bit sedated post-seizure, but you notice a big black eye and what looks like rope or ligature marks on his wrists. That's not typical of a seizure. You ask the staff casually, "Hey, how did he get this bruise on his face? Did he hit something during the seizure?" The staff member, looking nervous, says, yeah, he fell against the bed." You also notice the wrist marks. One of the other residents, who is more verbal, blurts out to you when staff isn't close, "They tie him to the bed at night." Whoa, that's a serious allegation. This is likely a case of physical abuse by caregivers, possibly tying the client down, which is illegal restraint and abuse. How are you, as the provider, going to handle this situation? You treat the patient for the seizure, check blood sugar, administer meds if needed, etc. But now you're also quietly gathering info. You might ask the patient gently, though he's developmentally disabled, he may not articulate well, or ask the resident who spoke up to repeat quietly what happens. Regardless, you have enough suspicion. You ensure law enforcement is notified. Maybe dispatch already sent them for an injury call, or you request them, stating you have possible abuse at a care facility. Transport the patient to the hospital for evaluation of injuries from the alleged tying and any seizure workup. En route, you document what you saw, like distinct red grooves on both wrists, approximately half-inch wide, resembling rope marks, and what the resident said in quotes. On arrival, you inform hospital staff and also your supervisor or directly call Adult Protective Services, since this is a dependent adult in a facility. A PS and possibly the state agency that licenses group homes will investigate. The police also take statements from the staff and other residents. Your documentation and timely reporting kickstart an investigation that could protect not just this patient, but other residents from an abusive caretaker. These scenarios underscore a few points. Abuse situations can be emotionally charged and complex, but noticing the key signs and knowing how to respond medically, safely, and legally is crucial. In each case, the EMS providers had to balance patient care with subtle investigative instincts, and then follow through with reporting. Sometimes you might feel like, is it really my role to get involved in this family situation? But it is. EMS are mandated reporters and often the first step in stopping abuse. Even if it adds extra paperwork or an uncomfortable conversation, remember the alternative. If we leave that child or elder in the same situation without raising the alarm, they could be seriously hurt or even killed the next time. This will conclude the Abuse and Neglect lecture series. Remember to stay alert, stay compassionate, and remember that your actions in these cases literally can save lives and change futures. Thank you for your attention, and thank you for being willing to be that lifeline for patients who can't always speak for themselves. Keep learning, stay safe, and continue to provide the best care and support for those who need it most.